Go for it.
Good, good. So, how are you all?
Not too bad, thank you.
Good, thanks.
That's great. So we are going to talk about hematological disorders and pregnancy, really. And I think so most of you know most of the stuff already. So looking at the learning objectives, I looked at your curriculum, and I think so it is CIP 12, where you have to manage non-emergency obstetric problems. So medical problems come under that. So in general, there are like same principles for most of the medical disorders in pregnancy. So I want you to have a knowledge of the following principles on the topics we discuss. So I'm like, it is a very, very large topic. So I'm unable to cover all of hematological problems in like 1.5 hours. So I've chosen the common ones. So you should have knowledge of preconception counseling, and you should be able to assess and manage these medical conditions in pregnancy, postnatal with MDT team, and understand the impact of pregnancy on the disease and disease on pregnancy, and can make management plans and prescribe safely. So just knowledge. So I'm like, this is the basic level of knowledge. So application of knowledge is in clinical settings. So hope you will get a chance to do that as well. So commonest disorder, medical disorder in pregnancy is anemia. Anemias in pregnancy. So I thought it's a long time. I have not revised my knowledge on anemias, and I was just going through to see if there is anything new. So we'll go through it. So definition. So any of you already know the definition? Then we can skip through. Want to share? Anybody? No. Okay. So in general, anemia is defined as low hemoglobin concentration. So usually 2 standard deviations below the mean for the healthy population. So it's WHO definition. And there are no, like, the definition in pregnancy is derived from non-pregnant population, and it is not linked to the clinical outcomes at all. So, but there is like international debate ongoing on this topic, and still the work is ongoing regarding definition of anemia in pregnancy. So currently there is international consensus that anemia should be defined if we have hemoglobin concentration below 110 grams in the first trimester, and then a lower level in the second trimester, and even a lower level in the postpartum period. And it is a common disorder, as we said, 50% in the low income and resource countries. And there was a study done in UK, which found that it is like a quarter of the population has anemia. And in pregnancy, there was about half of the population of pregnant women had anemia, either at booking or at 28 weeks. And another study found that the common cause is nutritional deficiencies, infectious diseases, or hemoglobinopathies. And that was an international study, so not specific to UK. So then I thought, let's explore what are the effects of pregnancy on anemia itself, because we know there are lots of physiological changes in pregnancy which can have impact on hemoglobin concentration. So most common is, as we all know, expansion of the plasma volume, which starts in the first trimester and it is plateaued by third trimester. By third trimester, the plasma may be expanded by 40 to 50%. And in actual amount, the red cell do expand as well, but to a low degree. So by third trimester, the expansion of the red cell is about 15 to 25%, so almost half. So there is relatively a dilutional state. So there is a physiological drop in hemoglobin, which is not anemia. And the other reason we are more likely to have anemia in pregnancies is increasing demand of iron because of developing pregnancy, demand by the placenta, uterus, fetus. And what is impact of anemia on pregnancy? So there are large numbers of studies done, and there are even meta-analysis done. So most of the studies, they only suggest there is link to maternal fatigue, poor quality of life, and obviously postnatal depression. And also there is some association with PPH, but that is more with severe anemia, like hemoglobin of 85 or below. And with severe anemia, there is a link with increased morbidity and mortality. But again, this large data is international data, and it is very difficult to extract exact data for the UK population. And regarding fetal risks, there is severe anemia linked with stillbirth and perinatal death and SGA. So that is why it is quite important to screen and treat anemia. There are also some studies suggesting there is a link with cognitive impairment, brain development, and stuff like that. But it is not proven by the meta-analysis or systematic reviews. It is more of the observational studies. So we do not have any such convincing evidence yet. So how you will manage? There are symptoms, but because of the pregnancy, it's very, very difficult to just screen anemia by symptoms, because the symptoms are very much same as because of the physiological changes of the pregnancy as well. So there is, in UK, we do routine screening, which involves full blood count done at booking and again at 28 weeks for all of the low risk pregnancy. But there are women you will identify they are at higher risk of anemia. So we can tailor this screening for them, especially people who have had previous PPH requiring blood transfusions, or who have other comorbidities like inflammatory bowel disease, a little bit of chronic renal disease, other medical conditions like hypothyroidism. They are at increased risk of iron deficiency and anemia. So on those cases, you could do a repeat full blood count at 34, 36 weeks as well, or screen for iron deficiency, which is ferritin. Because even with the normal hemoglobin, if you have low ferritin level, that means they're already deficient in iron and more likely to develop anemia. So that's useful. But again, there is issue with ferritin because it is an acute phase reaction marker as well. So people with inflammatory disease, you have to be careful. They can just have falsely high ferritin levels. So it is a bit difficult. Then there are other like markers. We can speak with hematology, like transferrin saturation can be done with people with IBS and things like that, inflammatory bowel disease, that can accurately tell about iron deficiency. And then again, there is a large debate in literature regarding routine supplementation. So still, from the data, there is no evidence that routine supplementation improves outcomes in pregnancy and reduces the risks because of the anemia. But again, this strategy has to be tailored according to your healthcare. But most of the low resource income countries, because they do not have resources to do routine screening, especially screening for iron deficiency with ferritin. So status there is that they do offer routine supplementation of iron, and there's a large practices in US as well. They are offering routine supplements in pregnancy as well. And there is recently a large study published which has suggested with, I think so there was 44,000 women involved in that meta-analysis that iron deficiency is extremely common, and 50% of women had low ferritin in pregnancy. So there is a debate going on regarding routine supplementation, but current UK practice is still that we are not offering routine supplementation just in pregnancy. And so only high-risk women, people with previous BPH or twin pregnancies, multiple pregnancies, or less interpregnancy interval and things like that, we can offer them ferritin levels to screen for iron deficiency and then supplement accordingly. And treatment of iron deficiency. First thing is treatment with dietary modification. I'm just coming back to see if anybody wants to participate and contribute. What sort of dietary advice you will give to women with iron deficiency?
The NHS has a good website about iron deficiency anemia, and they ask you to increase green leafy vegetables and to have like nuts and tofu and all sorts of meats other than liver, and lentils, dals.
Yes.
And with regards to iron supplementation, it's advisable to take it with orange juice because vitamin C helps improve the uptake of iron, and then to avoid dairy products 2 hours before or 1 hour after iron supplementation.
Yep. And same applies to tea, coffee, and tannins because they interfere with iron absorption. And so there is evidence that heme iron, I'm sure we all know from the meat sources, poultry and stuff, is absorbed 2 to 3 times more efficiently than non-heme iron. So yeah, that's one thing. Great. So we can keep interactive a little bit because I think so we've all treated anemia. So after that is oral iron, because it's cheap and easy to administer and low risk. So like what are the different regimes people have used?
So I think there's very limited evidence about regimes. I know there's a big study which has started in Oxford recently, and I attended one of the talks given by the people organising that study, and they were talking about how, you know, like giving iron twice a day, as lots of regimes do with the sulfate or fumarate or whatever, might just be increasing side effects without increasing the amount absorbed, and they're trialing giving stuff twice a day, once a day, or just several, like 2 or 3 times a week, and looking to see what has as good of an impact. And that certainly made me, when I do prescriptions, which to be totally honest often feels a little bit random, it kind of is in line with whatever somebody happens to tell me to do or whatever comes up first on the EPR. It's made me lean towards giving it slightly less because of this, like I think at the moment just observational data that maybe we're increasing side effects without increasing actual increase in HB.
I think the evidence there is the fact that the enterocytes lining the gut, they become overwhelmed, and basically they are not open to any more pickup of iron until about 18 to 24 hours later. So I think you're right, the drift is probably towards supplementing every 48 hours. No, not 18 to 24. I meant 36 to 48 hours. So I think the drift is towards maybe doing it every other day.
Yes,
but yeah, for now the practice hasn't.
I think so. There is a Cochrane review done on some other subject, but that has picked up this. So alternate dosing is more preferable. It does reduce the side effects because the side effects are because of unabsorbed excess iron. and improves the compliance, and it is effective. And the ferric salts are better than other preparations. Still, the evidence base is supporting that. Like we use ferrous sulfate or fumarate or gluconate. Those are the common preparations.
And do we know if there's a difference between those, like sulfate, gluconate, fumarate,
sulfate,
whatever?
I think so, it's better, but GI, some people can't tolerate, so then you can try the ferrous fumarate is the second most common used. The most common is ferrous sulfate used. So this is, yeah, there is emerging evidence having less dose, because again, yes, the absorption is limited. So by increasing you're just increasing the side effects, and alternate day dosing. That is the new trend. And I will show you the link, because what I got, all this information is from the British Society of Haematology guidelines, which is quite recently updated. So yeah, so you can read it for further details. So will be there. That is in the references. So that's about oral iron. I'm sure you all have prescribed and used the parenteral iron as well. So do we know evidence around it? So most important for parenteral iron is, I think, so we don't have enough safety data for first trimester. So first of all, that is important not to use in first trimester if you can. So the safety data is there for second and third trimester. And there are studies, they have suggested that increase in hemoglobin and increase in serum iron levels and ferritin is much quicker with parenteral. That makes sense because you're giving the big dose together. And so that is for like severe anemia in second or third trimester, the preferable treatment is parenteral iron. But it has to be confirmed as iron deficiency with ferritin levels. So that's it. But again, like with all these big problems, we still do not have a convincing evidence that iron treatment improves the outcomes in pregnancy. It's always a problem. Right, I think so we are pretty much done with anemia. You people want to ask anything or any questions? And I've just covered the iron deficiency anemia. So if people are at risk of developing other sorts of anemias like megaloblastic, the other common one are just deficiency of vitamin B12 or folate. There are a group of women with inflammatory bowel disease or people who have had a gastric bypass, bariatric surgery in the past and things like that. So they should be screened for that as well.
Mustafa, can I just ask very quickly about B12 deficiency?
Yes.
Because I remember years ago having a discussion with a haematologist saying, no, we shouldn't even measure routinely in pregnancy. We don't replace in pregnancy either. But
no, I think so. What I I just read for this presentation, updated myself a little bit, is that it is difficult to measure. So that we do not have reference data for vitamin B12 in pregnancy. Again, it was quite interesting to know there is a big debate on ferritin. So what cutoff should be used in pregnancy, and because there are not many studies in pregnancy to exactly tell what is normal and not normal in pregnancy. Even hemoglobin is all based on non-pregnant women. So that's why, because there are always those issues. So what is the cutoff? Where should we treat? So these are the problem. But the high-risk population, especially the women who have had bariatric surgery, because they do not absorb much, so they need parenteral sort of supplementation. So for those high-risk women, they are screened outside the pregnancy as well. So for those women, there are suggestions by the British Society of Haematology.
that's helpful, thank you.
And give supplements as well. Right. Okay, so that sort of is quick talk about anemia. So other one as common is, just go back. Other common problems we see in pregnancy is hemoglobinopathies. There is wide range, but there are two common groups. One is thalassemias. You all know that. I don't think so. This will be just a quick revision. What quick revision means interaction. So yes, who wants to tell me about thalassemias? Just the common, like the part one sort of thing.
So I guess they're genetic genetic conditions related to the alpha or beta globin chains, and they can be related to like deletions or just mutations in those genes. And there's a variety of phenotypes, going from really severe, such that either non-viable pregnancy or very significant symptoms throughout life, or I guess where it maybe is perhaps more obviously relevant to pregnancy is that there might be people who only become symptomatic during pregnancy when they are stressed, or like when their like physiological circulatory system is stressed, let's say.
Yes, great. That's good overview. So if we want to go in details, then yes. So why it is? I should start in the. All right. So there are hemoglobinopathies are two types. So thalassemias are where the production of alpha or beta chains is impaired because of genetic defects. So there are two major types. One is because there are two major types of the hemoglobin chains. One is alpha and beta in adult hemoglobin. So there are two types of thalassemias. One is beta and one is alpha. So in beta thalassemia, there is defective beta globin genes, and there will be excess of alpha. So there is imbalance of hemoglobin, and there is more hemolysis and breakdown of RBCs, leading to anemia and also hemolysis. So we carry everybody carry one gene, so two genes. So you get one from each of your parents, and if there are two defective genes, you have got a major thalassemia. And if you have two defective genes, but the penetrance of these genes is different. So one could be a partially functioning gene, which is called intermediate. That was new to me as well when I was reading. And that has a slightly milder disease, but less common, not very common. And the other one is when you have one gene carried from one of your parents, then it is minor. So that's called thalassemia minor or carrier state, which is quite common. And we see in pregnancy as well. And on the other hand, alpha thalassemia has got more genes. So you in total have 4 genes, and they can come from both of your parents. So if you have one gene missing, you hardly have any symptoms, no problems at all. And if you have 2, then it's mild anemia. And if you have 3, it is called hemoglobin H disease, and you will have blood transfusion dependent chronic sort of anemia. And 4 faulty genes is not viable, and you have hydrops fetalis and severe anemia in utero and a very complicated pregnancy. And I think so that have impact on mom as well, with severe preeclampsias and other stuff. So impact. And luckily, these both disorders are autosomal recessive, which is great. And previously we were saying that that is less common in UK population, but now because the population demographics are changing and we are seeing more of these disorders in UK. That's a nice picture, which I copied from, RCOG e-learning. So if you want to have a look in a descriptive way, it's quite simple. How you get the beta thalassemia. So that will help in counseling. And this is an activity for you people to do. So I give you, do you want to, I think so it is difficult on teams to make groups. So maybe if you have numbers of each other, you can work in a pair or otherwise alone to just do this little.
Yeah, I've not quite figured out the teams, the group side of it. So everyone's just going to have to work solo, I'm afraid.
Well, I've done one teaching for ST3 and 5s, but I had more time. So I asked them to make groups because they all have each other's phone numbers so they can call each other.
Oh, there you go.
It's a bit difficult.
Depends how motivated everyone is.
Not a friend, that's fine, to work together. So I'd probably say 3 to 5 minutes should be enough. Not many fill in the blanks. Come out and see you on the Teams. Yeah, so yeah, 3 minutes. Can you still see?
I can't see the slide anymore.
No, it's gone.
Okay, fine. I'll go back. Slideshow from this one. Can I select?
I might just try and attempt to do some rooms. So if it changes, then hopefully you guys will go into rooms. If not, I'll.
If it takes too much time, then
Let me try.
try.
Is anyone in the room yet? Oh, there we go. It's worked. Hello?
Oh.
You're
Okay,
back.
you guys are back. Excellent. Not as smooth as I hoped, but hopefully you guys have had a chance to talk. Okay, Mustabshir, back to you then.
Good.
And hopefully everyone's back. They should be.
Looks like slowly. People
Sorry, Miss Bias, I couldn't unmute myself, so I was just sat there in silence in the room.
And you're just listening to us.
I was just earwigging.
That's okay. Thinks we're back, isn't it? So who wants to have a go and tell us the answers? Nobody?
Did you want to put that screen back up, your presentation? Maybe that might be helpful.
All right.
Thank you.
Anybody wants to have a go? All right. I'll be kind. That's the answers. So at least somebody can read for me now. I'm tired of talking.
I don't think we can see it.
Do anything.
Yeah, you're not sharing just yet, Mustabshir.
Oh, okay.
Can't see it.
I thought it's automatically done when you come back, but fine. I'll try again.
Come on, guys. I'm sure you
Oh, yes.
muster a bit of enthusiasm.
It is coming back. And you can see now?
There we go.
Answers. Who wants to read?
I can read it. So thalassemia is inherited in an autosomal recessive fashion. The parents of a child with thalassemia are referred to as obligate heterozygotes, which means that they each have a single copy of the HBB gene. Those with a single copy are called carriers, or those having thalassemia minor. Whilst they usually have no symptoms, they can sometimes be anemic. Each sibling of an affected child has a 25% chance of also being affected, a 50% chance of being a carrier, and a 25% chance of being neither affected nor a carrier. Each child of an affected parent must receive one copy of the HBB gene from that parent. Such a child is referred to as an obligate carrier. Conversely, the parents of an affected child must have a single copy of the HBB gene and is known as an obligate heterozygote.
Yeah. So yeah, it's just, they've just put in with difficult words. I think so, just to make things difficult. But I think so, we all read about it, all this like family tree and inheritance, and forget it again because we don't really use it every day. And whenever you have to consult somebody, you just go and have a quick look. Okay, fine. So yeah, and then you can easily counsel women. Lovely. Next is.
Can I just ask, what's the difference between an obligate carrier and an obligate heterozygote?
Heterozygous, this is just the phenotype and genotype, isn't it?
Okay, so it's the same thing. But...
So, and I found this interesting colorful picture showing different sort of globin chains. So this is types of hemoglobin. So in adults, HbA is the most common type. In fetal life, HbF is the most common type. So that's why it doesn't have that much effect in the fetal life. And that's why in adult life you need your 2 alpha and beta genes. So next common hemoglobinopathy is sickle cell trait or disease. Disease is rare, especially we rarely see pregnant women. Has anybody had any experience or been involved? Want to share? I've only seen one case in my career.
I've not seen any, to be fair.
Well, like seen means like when I was a registrar, seeing in the assessment unit, you know. At least I can say like I've seen one, but
The trait, but not the full disease, no.
not like completely looking after in pregnancy and things like. But yeah, there are people around. So with sickle cell, what is the physiology? It is the defect in hemoglobin structure, not just the chains and deficiency. So structure of the hemoglobin is variable, and again depends on phenotype is heterozygous or homozygous, that you got two genes, which is called sickle cell disease, which is HBSS. So you have two sickle cells gene. So that's the severest type of the disease. But in there as well, penetrance of this disease is variable, and people with same genetic defect can have different phenotypes. So there are some people have severe disease, some intermediate and type as well. Again, it is autosomal recessive disorder, and there are quite different variations and different combinations of HBS and C, sort of intermediate disease and mild sort of HBS and B thalassemia. But sickle cell trait is the commonest condition we see, which is just a milder disease, and most common is anemia. So what is the importance regarding pregnancy with all the hemoglobinopathies? What is the most important thing in pregnancy and management after all this discussion regarding genetic stuff? I think this is prenatal screening, isn't it? Most important is if we can do ideally have a preconception counseling, that is great. And so it's explaining the risk to baby. So prenatal screening is offered. And the first step is partner testing for most of the carrier people, because if the partner is not a carrier, then risk is minimal, extremely small of transmitting. But if both are carrier, then we already have gone through, there is 50% risk of child being carrier, or 25% risk of disease. So I have it written here on next. So regarding prenatal diagnosis, I was looking up. I've had a patient who had PGD, because that is available now for the sickle cell carrier. If both couples are, both of the partners are carrier, so that is available, and then you can apply for that. So PGD is the ideal thing you can do. And other is CVS, because that can be done in early pregnancy, but they are invasive tests, CVS and amnio, both of them. And I was looking up for NIPT, but we do not have still an established test regarding hemoglobinopathies because of different penetrance and a little bit of mixing of maternal blood as well. So we still do not have a cutoff where we can say high and low risk, but there is work ongoing regarding NIPT. And so how we manage in pregnancy, because again, most of these cases are asymptomatic, so they are screened. And this is a routine screening in antenatal program by full blood count, then ethnic origin questionnaire, then this like abbreviation, I think, so I looked up, it is chromatography, high something, and then electrophoresis and other like specific tests. So if the questionnaires come back high risk, then one or two of these tests are done to confirm hemoglobinopathies. What of impact they have on pregnancy? With the minor disease, it is just risk of anemia. So they have low hemoglobin, but because of most of these diseases are hemolytic, so they do not have iron deficiency. So the treatment, if there is iron deficiency, you can do ferritin levels, then you can give them oral iron. We never use parenteral iron for them because they are not at risk usually of iron deficiency. they are at risk of iron overload. And if there is severe anemia, then it is treated with blood transfusion. And for major disease, the management is complex, because that's why I've not gone through, because the issue is how much the disease has impact on multi-organs, how many organs are involved, and then they are managed with MDT team with tertiary level centers. Normally, if I will have a patient here at RBH, either I will manage them if they were known to some tertiary level center already. UCLH is in London and or Oxford. So because with beta thalassemia, which I have never seen a pregnant woman yet. I was in Pakistan, I've seen children, loads of children who had this disease, but it has major impact because of iron overload. There is hepatomegaly, splenomegaly, lots of other organ failure, renal, cardiac. So it's quite complex if they reach to reproductive age and manage to get pregnant. So it has to be a quite wide MDT management. There is an RCOG guideline I found out about beta thalassemia major. If you want to read in too much detail or look for reference, then there is some data. But that was published in 2014 and it has not been updated. And with the sickle cell, again, management is MDT. And the complications are slightly different. So in sickle cell, the main issue is normally because of the sickling of the cells, there is more ischemia of the organs and occlusion of the blood vessels. So they have more crisis, painful crisis, and hemolysis and ischemia and occlusion can do organ damage. And there is more atrophy because of the avascular nature of this disease. There is not splenomegaly, there is hyposplenia in that situation. And there are other crises like chest crisis, and all these have to be managed by multidisciplinary team. Again, hematology and anesthetic involvement is quite important because I think so hypoxia can trigger these crises. But again, evidence is low. When I was looking in, it's like too much research has been published about it. So that's why it is complex. So it has to be MDT managed. And these are the links if you want. For sickle cell disease, the guideline is published by British Society of Haematology, and it's quite recent. I think it's a 2021 or 20, quite recent one. So that's, I just come out and look at you people to see if you have questions or anything. Anybody want to share any experiences? No? Okay, good. Yeah, one thing I forgot to tell, with both of the minor disease, like with sickle cell and thalassemia, there is no modification of normal routine pregnancy care is required. Sickle cell trait is, especially in Black ethnic population, is linked with a little bit higher risk of thromboembolism and bacteriuria. So that we just have to be mindful and watch for that, okay? But other than the rest of the pregnancy care does not need modification, other than prenatal diagnosis and management of anemia if required. Right, so let's go back then and go to the next topic. Or if you want 2 minutes break or something. I've been talking pretty much nearly 40 to 50 minutes. You're okay?
I think they're good. I think they can, if provided you're okay, Mr. Bashira.
I'm fine, thank you.
Thank you.
Right, so go back to the full screen. Next, I thought, because there are two types of the clotting disorders, isn't it? One is thrombosis, risk of thrombosis, which we deal with so much in everyday life. I thought that's a bit boring. So I've gone to the other disorders. Again, platelet disorders, they are common as well in pregnancy. I think so pretty much all of you must have encountered thrombocytopenia at some point, and because it is common. So there are 4 main reasons why we can see people to have thrombocytopenia in pregnancy. The definition is less than 150,000 per microliter. And if they are more than 100,000 per microliter, then we have to think about other than pregnancy-related causes. So the commonest cause is gestational, just because of the pregnancy, physiological changes, and in some women, there is a more impact on platelet count with hemodilution, and so you see a lower levels of platelets, but that is more common in 2nd and 3rd trimester. If you see thrombocytopenia in 1st trimester, then you have to think about other causes, not just the gestational. And again, these are all diagnoses of exclusion. I'm sure you all know thrombocytopenia in isolation can be due to many other causes. Could be infection, could be viral infections, could be because of deranged liver functions. In late pregnancy, you really definitely have to think about preeclampsia or HELP syndrome. But in those situations, you will have other abnormalities rather than isolated thrombocytopenia. So that we have to be mindful. You have to take good history, and some drugs can cause thrombocytopenia. So there's a whole list of things which you can look and make sure we exclude them before we just say that it is either gestational or ITP. And it is very difficult to make difference between both of them if we first time see the low platelets in pregnancy. And I have had like a couple of patients of ITP. One of them had a booking platelets of 33. So it was quite low. And so they are mostly managed in conjunction with the hematology team. So that is about. So with there are discussions regarding ITP and the diagnosis. And some people think because it's autoimmune, so testing for antibodies may help, but literature is saying contrary. Testing regarding antibodies is not required for the diagnosis because it's not present in all of the people with ITP, and can be intermittent as well, so can be positive sometime and negative on occasions. So it is more diagnosis is just by exclusion and by previous history of thrombocytopenia as well. But there is, yes, the literature suggests that we see more commonly in pregnancy. I think so. If there is a little bit of borderline ITP, it becomes more pregnant, more prominent in pregnancy, and this is a disease of more of women, autoimmune disease, more of women, common in women. So that's why we see more in pregnancy. And the other common condition is pseudothrombocytopenia, which quite a lot of time we see like, oh, okay. And then there is a comment that platelets are clumped. So they are just because of the lab error and because of the excessive EDTA, they get clumped. So they just need to do a film and count it manually. So we have to be mindful of that. So just don't act on one, just blood test. So we need to repeat it and speak to the lab. So most of the time either it is ITP or it's gestational if you exclude all other causes and or you're mindful of that. Management is pretty much the same. So if the platelets remain more than 100, there is nothing specific needs to be done. So in early pregnancy, you can monitor them monthly, and then when time is coming closer to delivery, then you can monitor them more closely, like once a week. And if the platelets are low, about below 80, then it is better to discuss with the hematology. And if it is, we're suspecting ITP, there are some immunosuppressant treatments which can help to improve the platelet count, which is most common treatment is steroids. Rarely IV immunoglobulins have been used, cyclosporins as well, or extremely rarely you need platelet transfusion, but it has a limited role and it is only used for the acute bleeding or just to cover for the delivery, because it is an autoimmune condition, and if you throw the platelets in, they are going to be just destroyed because with the antibodies. So that has to be last resort in the discussion with the hematologist, just to cover the hemorrhage and acute bleeding and things like that. Again, like threshold for treatment is quite low. Again, it is with discussion with hematology. So the patients I was talking to you, the one, she was para 1, and so she had a normal delivery 15 years ago, and that was her unplanned pregnancy, and she had no previous history of low platelets, and it was just her booking platelets were 33. So after exclusion of other causes, this was presumed to be ITP. Her platelets remained pretty much throughout pregnancy below 80. And as far as they are above 50, most of the hematologists will not treat because function of the platelet is quite good and the risk of bleeding is very low if the platelets are above 50. So that's why she was not treated. I even offered her induction of labor at 39 weeks to time the delivery. So in case she doesn't end up in having a home birth with low platelets, which she's declined. And then she had uneventful vaginal delivery and was fine. So that's what it is. A risk of massive hemorrhage is only like possible, or risk is if the platelets are very low, around 20. And there is one other rare condition which is worth mentioning because that is again more commonly seen or presented in pregnancy, is thrombotic thrombocytopenic purpura. So it has pretty similar picture, but it has symptoms because of thrombotic events. Mostly it presents along with neurological symptoms. So then it is important to involve hematologists early. Delivery, immunoglobulins, and other stuff is not a cure. So it has to be just managed by plasma exchange or plasma infusions. There is a registry of this in UK, and they have been successful pregnancies managed with GTP, just with plasma infusions. They normally start in very early in pregnancy, around 5 weeks, and then manage them weekly throughout pregnancy. Right. So any questions regarding thrombocytopenia? I think sometimes I feel I'm going very fast, but do stop me, please.
Mr. Shah, can I just ask a quick question? Because we're using enoxaparin at the moment.
Yes.
The anaesthetists, some of the anaesthetists will having come from a different unit. So we go for a level of 80, don't we? But they seem to think with enoxaparin, if someone's been, so if someone was on,
yes.
Oh God, what was my question? I think starting TINs again.
Starting prophylaxis, yes.
Yes. Is it any different with enoxaparin compared to tinzaparin, the levels?
No.
Okay.
In consensus, what my understanding is, if your platelets are below 100, you're unlikely to clot. So there's the most common consensus. So if your platelets are above 100, then you should have thromboprophylaxis.
Okay, fine. Yeah, thank you.
Yeah.
Can I ask a question about postnatal follow-up?
Yes.
Do these women, sorry if you already said it, do they need bloods to be taken in the postnatal period to see if the issues have resolved, or what's the follow-up recommendations?
The people who have a severe sort of thrombocytopenia, where hematology is already involved, they will follow them up after 6 weeks to do additional tests to exclude other causes like myeloproliferative sort of bone marrow if they have to do studies and stuff like that. So they're okay. People who we think who are gestational, then their full blood count can be just checked 6 weeks by GPs, and if they are still thrombocytopenic, then they need a hematology referral. We do not routinely refer them to hematology. So it depends on the levels, yeah. If it is severe, yes, definitely hematology follow-up.
Thanks.
And regarding delivery plan, if the platelets are less than 100, they're pretty safe, more than 100, they're pretty safe to even have a home delivery or deliver on birth center. I do normally allow them. Okay, okay, I think so. Gone backwards again. No, fine. You people can still see? Yes? We covered.
Yes.
So the other condition, which is not that common, but I have come across a couple of cases. I'm not sure about other people. Thrombocytosis. Have you seen any cases in pregnancy? I thought maybe just touch that as well.
Yeah, I've seen women with slightly raised platelets, and normally people have thought that it's reactive in relation to infection, like the first point on your slide.
Yeah. I've come across as well a couple of them which are sort of unexplained, idiopathic and stuff. And one patient I had, or two patients I had quite interesting. One was polycythemia vera, which was good, but they are again managed with multidisciplinary team and tertiary level centers. So that was good. So they are treated with interferons, and if the levels are really high, they have venesection to reduce. And they can get neurological symptoms if the platelets are very high. And then in pregnancy, like we just monitor them monthly, platelets similar to the thrombocytopenia, and then at end of gestation weekly, and do thromboprophylaxis. If they are in the normalish range, aspirin is enough. If there is a little bit higher range, then low molecular weight heparin. Offer them growth monitoring because of the thick blood, with the thrombocytosis, there is more resistance, presumed to be, to the placenta cell anyway. So they can have growth scans to monitor growth. So the pregnancy I managed in a young lady who was under care of UCLH as well was quite successful, and she was good as well. Her platelets pretty much remained normal because she was on interferon alpha. And she, I think so, opted to have induction at the end around 39 weeks and had a normal forceps delivery and normal blood loss about 800, and it was good. So they're easy. So some without diagnosis, if suddenly you see, so yes, most common is reactive sort of thrombocytosis, either to infection or to iron deficiency as well. So I have currently one patient which has platelets like that. She has no previous history of thrombocytosis. She was para 1, so previous pregnancy platelets were normal. And this time at booking, her platelets were more than 450. And then her ferritin her hemoglobin was normal, 113, but her ferritin has come low. So it is more reactive because of the iron deficiency and the bone marrow production. So there is a little bit of thrombocytosis. So we hope she will respond to iron treatment, and when we check a couple of weeks, hope things will be better. That is one thing to check. And if obviously the levels are very high, then we will have to liaise with hematologists to rule out myeloproliferative disorders and stuff like those, which are a bit more dangerous. but in the intermediate sort of range, more common the benign causes. And aspirin is enough for anticoagulation. So that's about it. So rather than coagulation disorder, because I'm sure you know a bit more than that, because we deal with them more on a daily basis, like thrombosis and pulmonary embolism and things like that. So I thought it would be good to revise the inherited bleeding disorders, because we don't see them that frequently. The commonest inherited bleeding disorder, and then again there is a quite recent RCOG guidance about inherited bleeding disorders if you want to see details. So the most common one is von Willebrand disease, and the next one is hemophilia A and then B. It's quite interesting. Von Willebrand disease inheritance is very complex. Like it's difficult to understand. And it is common, 1% of the population may have a faulty gene, and it is on chromosome 12. So von Willebrand factor is a plasma protein which has two main functions. Either first one is to stabilize the factor VIII, and the second one is adherence of platelets to injured blood vessels. So quite important. So you can, I think so there is a little bit of evidence of screening some population, especially women who have menorrhagia at the onset of menarche and things like that, and easy bruising and bleeding. I think so the first line test is bleeding, or bleeding test for that one as well. So classification is complex, but I just remembered there are three simple things. There are three types. So the type 1 is the quantitative. That means the platelets are functioning, but the quantity is less. So that is luckily most common, which is 75% of the cases. The type 2 has multiple subtypes, but the most important is that the numbers are okay of the von Willebrand factor. Quantity is okay, but quality is not good. So there is nothing much you can do about it really, because you can't improve the quality of von Willebrand factor. So luckily, it is not very common. The third time is like very little amount or negligible von Willebrand factor. So that is quite serious. And again, as nature is protective, the first two types are autosomal dominant, and third type, the dangerous one, is recessive, luckily, which is good. And there is some of the type 2 or autosomal recessive as well. It's quite confusing one. But anyway, whenever we have to consult, we all can always go back to resources and look. That's like joy. A diagnosis itself in pregnancy is difficult, because you all know pregnancy has a huge impact on hematological factors. So any sort of screening is difficult to do in pregnancy. So same principles if we follow, then starting with preconception, ideally preconception, we should be doing the genetic counseling, and so only one type, the type 1, which is quantitative deficiency, responds to desmopressin. So we should be testing that there are different, not everybody responds to desmopressin, so a response test should be done. Normally the factor 5 von Willebrand factor increases after a couple of hours, 5 to 6 hours of desmopressin challenge. And genetic counseling is important, especially for type 2 and type 3. And prenatal diagnosis currently should be offered at least to type 3 disease, and it is again like invasive testing only currently available, not NIPT. And invasive testing should be done with von Willebrand factor cover or desmopressin cover because of the risk of bleeding. And then it's important to discuss potential risks in pregnancy and delivery in the preconception counseling. Antenatal, as we discussed, prenatal testing with hemostatic cover, joint hematology obstetric clinic. We do not have currently a joint clinic in RBH, so it is just we have to increase the communication with hematology. Sometime we get a reply if we're lucky in a couple of weeks' time, which is, but I think so. That's more for non-urgent. If we have situations like this, I'm sure they will respond a bit early, or we can discuss with the on-call team. So again, so we can do the testing of levels of 1 Willebrand factor in the first trimester, then again in the third trimester, and involvement anesthetist is important. So intrapartum care is all depends. In type 1 disease, that's the only one where levels are improved in pregnancy. And type 2, there is no change in pregnancy because it's the qualitative issue, not the quantitative. And type 3 is again like there is no change in pregnancy. So luckily for type 1, the outcome is better in pregnancy because naturally there is increase in levels. So if levels are normal in third trimester, you can pretty much treat as a normal pregnancy, but try to avoid invasive procedures like rotational deliveries in 1-2s, manual rotational lift out forceps delivery is okay. And if that is usually plan is made in conjunction with hematology regarding the management, and if required, we can give them tranexamic acid during labor in postnatal period, or factor support, or DV, desmopressin. The risk is postnatal because soon after the delivery, the levels go down. And then there is risk of PPH, especially secondary PPH, because the levels are going to gradually down in postnatal period. So there should be an antenatal plan to use either desmopressin or depending on the levels and severity of the disease, or just the tranexamic acid. Most people use it for a couple of days, at least 7 days after delivery. Has anybody had experience of that? Anybody have seen von Willebrand disease? Anybody want to share? No, I have seen one, and that will stick to my brain because again, like I was, it was in my reg years, I think so, ST3 or 4. So that was type 1. So she was managed with desmopressin and then tranexamic acid as well. But unfortunately, she was readmitted on day 4 with secondary PPH, which was managed okay. But the reason I can remember her was because she started having some neurological symptoms, and then we did her Eugenes, and she had hyponatremia about 121 and required ITU admission, and that is one of the side effects of desmopressin, which probably we overlooked. So that's why I will remember that case forever. So that is we have to remember.
We had an interesting gynae case during the night shift. It was a type 3, which was very severe, and it wasn't obstetric, but she essentially had admitted and had found to have a hemorrhagic ruptured ovarian cyst. But although this is very common, she required surgery because she had quite a large hemoperitoneum because of this, and she had to be transferred to a tertiary center. Whereas it would be something simple otherwise because of her type 3 von Willebrand. She needed specialist help. But she was a para 2 with 2 vaginal deliveries, which she said were uncomplicated, despite all of that. So.
I think so for those they do with factor support because there is a link between 1 Willebrand factor and factor 8. So that's how they manage them with factor 8 support. Great, that's nice. Yeah, no, I haven't seen type 3. So the next group is hemophilias. It's quite interesting, even if we don't see them often. It's good to revise. I do have 2 patients with hemophilia. So we all know hemophilia is a group of disorders, bleeding disorder. associated with low clotting factors, one of them. So in a hemophilia A is factor 8 deficiency, and a hemophilia 9, like B, is factor 9 deficiency. It's called Christmas disease as well. And there is another one, factor 11 deficiency, which was used to be called hemophilia C, but it's not anymore, but that's a bit rare one. The first two, A and B, they are X-linked, as most of us know, but we have to remember with hemophilia A, it is common to have just de novo mutations, new mutations as well. And they are quite common, 30 to 50% of the hemophilia are just a new mutation. But otherwise, they are X-linked recessive disease. And factor 11 one is autosomal recessive. Right, so that's what we have learned. And the severity is categorized by the factor levels. And same like with the same genotype, the phenotype could be different. Some people can have just a milder disease, some moderate and some severe. So this is the levels, depending on the level. If the level is obviously very low, it will be a severe disease. So this is autosomal and recessive, and it can affect both female and male because it's not X-linked, and there is poor correlation between levels and risk of bleeding. So prophylactic factor 11 is given in labor, or if there is induction. Luckily, it is not very common. So management is again same with all the disorders. You have to think about preconception, prenatal diagnosis. PGD is available for hemophilias because, especially for A and B, because it's sex-linked. Fetal sexing can help. And IPT is available for fetal sexing, so that is useful. Rarely you need to do invasive testing if somebody really wants genetic diagnosis, but most of the management is just done for hemophilia A and B, just upon male and female fetus. So currently the patient have been involved. She is a hemophilia carrier. Her dad had hemophilia A, and she is para 1. Her previous pregnancy was pretty much uneventful. She had a normal vaginal delivery, and that was a female fetus. And this time she was seen early in the fetal medicine. They did fetal sexing scan, but that unfortunately was wrong. She had invasive testing, which showed a male fetus. And yeah, so they are managed in conjunction with tertiary level. For us is Oxford, and the male fetus, if they are delivered at tertiary level as well. And if they have female fetus, then we can deliver them in the local units, depending on the hemophilia, like factor 8 levels. So recommendation is they have factor 8 levels done in all trimesters. And if the levels are quite good, then you can manage them in the local units. So that's how the hemophilia is. I haven't seen hemophilia B. I've seen 2 hemophilia A patients. So intrapartum care and postnatal care is all same in conjunction with the hematology, and depending on the levels of the factor. In the mild cases, you can just use tranexamic acid or desmopressin for hemophilia A. And you know it's only factor 8 which changes or increases in pregnancy. Factor 9 does not change in pregnancy and does not increase. So there is recombinant factor 8 and 9 available as well to use to increase the levels to provide intrapartum care. Regarding, I think so, most male fetuses with the women who are high risk carriers and with the low levels, most units plan the elective cesarean sections, the most atraumatic delivery, because the risk of intracranial hemorrhage is quite high. But for female fetuses and sort of normalish to moderate levels close to delivery can be managed just vaginal deliveries. That's about it, really. Any questions?
Thank you very much.
I think so. I finished just before my time.
That's lovely. Great. I'll just stop recording.